Hello, I'm Erica Crawford. Thank you for taking the time to complete the pre-survey, education, and post-survey on alarm fatigue and mitigation. Alarm fatigue is a major healthcare burden resulting in staff and patient dissatisfaction, delirium, and alarm complacency. A study at Johns Hopkins in 2016 found that in a typical ICU, there are 350 alarms per patient per day. The study also noted that patient safety increased when alarms were adjusted to increase specificity of actionable alarms and to decrease the incidence of non-actionable or nuisance alarms. Nurses are the primary managers of alarms in an ICU setting. However, a multidisciplinary approach that involves respiratory therapists for ventilator alarms and nursing assistants for call bell alarms results in a quieter healing environment. Continue on to watch for some concrete steps about how to mitigate alarms in our ICU. And again, thank you. Now we're going to talk about some concrete steps that you can take to manage your alarms and avoid alarm fatigue. The first note is alarms should always be on. Do not turn off alarms. If a parameter is not being monitored, remove it from the screen entirely. This is especially true for QTC and ST monitoring, which is performed manually. In order to remove the ST overview, just press the ST and toggle to off. This will remove that monitoring permanently, and you can feel free to measure your ST manually. Same is true for QTC. Sometimes a parameter is being overviewed, but the alarm is silenced permanently. This would be the case in somebody who we cannot achieve an adequate pulse ox reading for, and instead we are monitoring pulse ox or blood oxygenation via ABG. In that case, you can feel free to take the parameter off your screen and add a rationale in a note. Next, we're going to talk about heart rate or EKG monitoring. You want to increase specificity by adjusting for rate, ectopy, and rhythm. You also want to make sure to change your electrodes daily and as needed. The default settings for the heart rate monitor is 120 beats per minute and 50 beats per minute. As you can see, my heart rate is greater than 120. And so in this case, if this is a known rate and you are aware of it, you may be treating it, or you may have a mandate to allow such a high heart rate, you want to go ahead and adjust your parameters. Do that by selecting the heart rate and selecting high limit, and then change your parameter to wherever the mandate is that you are looking to make sure your patient doesn't pass. For example, if the doctor has ordered an amiodarone drip for a heart rate greater than 155, you may want to set your alarm to 150 so you're alerted to that change. Electrodes work with electrically conductive gel. The ions in human sweat complete the connection between the ion-filled gel and the EKG electrode. Skin contact is essential for the electrode reaction to produce an adequate waveform. Newly placed electrodes may not initially produce an adequate waveform until enough moisture has accumulated between the electrode and the skin. Old electrodes, especially those with no good contact with the skin, are exposed to air and result in drying of the ion-filled gel. In patients with known and stable ectopy, you want to adjust your ectopy settings. Remove alarm overview for benign, known, or chronic ectopy like PVCs, PACs, bigeminy, or trigeminy. To do this, you're going to select the heart rate and select arrhythmia. You can go down and select from a list to either increase the specificity of when the alarm sounds, like how many PVCs per minute do you want to be alerted to. The default is 10. For somebody like a STEMI with known PVCs, you may feel better about increasing this to 40 or 50, or turning the parameter off completely by toggling it on and going to 99. You also want to adjust your rhythm settings. Remove alarm overview for known chronic deviations from sinus rhythm. This would be, an example of this would be a patient with chronic AFib. To do this, select the heart rate monitor. Again, go back to arrhythmia, come down until you see the parameter for AFib and toggle it off. Your patient could still be monitored for rapid AFib as long as you set your heart rate to alert you to an increased rate. You also want to adjust an overview to note a paced rhythm. To do this, again, click the heart rate monitor and notice the paced mode here. For patients where you are unsure if they are paced, if they have what feels like a permanent pacemaker, but you're unsure if it is on or working, you can hit unconfirmed. For a patient with a known pacer, whether it be a TV pacer, transcutaneous pacing, or a permanent pacer, you would select on. And for all other patients, you would select off. This increases the specificity of the monitor and allows it to pick up those pacing spikes a lot easier, and it engages the machine learning that tells you that this is a paced rhythm. Now we're going to talk about pulse oximeter monitoring. Ensure an adequate site that results in a stable pleth. The pleth, or plethysmograph, actually measures the change in volume in a body organ like a fingertip. Therefore, if you have poor collateral circulation, you won't have a good pleth, and therefore your SpO2 monitor may either be erroneous or may be difficult to pick up. Change sensors for your pulse ox daily and as needed. Default settings are a high of 100% and a low of 90%. Adjust pulse ox for highs and lows that are outside the default range when they are known and non-actionable. Example is when a patient that is being monitored via PaO2 on ABG rather than SpO2 secondary to poor perfusion. Now we're going to talk about the respiratory rate overview. You want to ensure adequate electrode placement. These will be the white and red leads, with the white lead being the primary lead. The respiratory lead works on the concept of impedance. Ensuring that the white lead overlies the chest and the lung tissue below will result in a more defined respiratory waveform. Conversely, if the white lead is placed on or above the clavicle or near the shoulder joint, the sensor's ability to report impedance will decrease, resulting in a dampened waveform or increased artifact. Default settings for the respiratory rate are high of 30 beats per minute and a low of 8 beats per minute. Apnea time limit is set at 20 seconds by default. Default overview monitoring is set as auto. Adjust overview monitoring to manual. Changing to a manual overview allows you to size up or down the respiratory waveform and allows you to adjust the manual reference line, essentially the eyes of the monitor, to capture the peaks and valleys of the respiratory waveform. And this is how you do that. You're going to select the respiratory rate, and you'll see that it's set by default to auto. Change that to manual, and what eventually pops up is a manual reference line. Therefore, I can adjust this line up or down to see the peaks and instead not the valleys of my respiratory rhythm. So I can adjust by sizing up my actual rhythm and moving the reference line up or down based on the size of my waveform. You want to adjust the default respiratory rate alarm to reflect your patient's actual known stable respiratory rate. This is especially important if your patient's on the ventilator and the set rates are outside the default settings. If your patient's rate is set to 32, it's going to alarm because the patient is breathing over the alarm parameter. Setting the highs and lows is easy. You select the high and you can go up based on what your patient is actually doing. Additionally, because this is one of the most erroneous and non-actionable alarms that our monitors will produce, setting the apnea alarm to 40 seconds gives a little bit more give when you haven't actually touch the peaks of your respiratory rhythm, and therefore it's erroneously reading as apnea when apnea is not truly occurring. Additionally, apnea is a fairly common condition. Somebody may actually go outside the threshold of the 20-second default setting without dropping a pulse ox. So resetting your high, low, and apnea time limits will decrease those non-actionable respiratory alarms. Now we're going to talk about non-invasive blood pressure monitoring. Ensure that the cuff size is appropriate for the patient. Change the cuff daily and PRN. Default settings are systolic blood pressure high of 160 millimeters mercury and systolic blood pressure low 90 millimeters mercury. Additionally, a MAP default is set at a high of 110 millimeters mercury and a MAP low of 60 millimeters mercury. Increase specificity of results by assigning which portion of the cardiac cycle to monitor, systolic, diastolic, or MAP. A combination of the parameters may also be appropriate. Do this by selecting the blood pressure parameter, and you can assign which area of the cardiac cycle you want to overview. In the absence of an MD-ordered blood pressure target, all ICU patients should be adjusted to MAP overview only. This is specific to clinical situation, of course. If a patient has no MD-ordered blood pressure target, use clinical picture to decide the best portion of the cardiac cycle to monitor. An example would be a patient with a brain hemorrhage and who is also hypertensive. In this case, systolic blood pressure may be a more appropriate metric to overview. Adjust the highs and lows according to the patient's known, stable, and non-actionable historical results. If you are mandated to treat a blood pressure of a mean less than 60, go ahead and set your parameter to 60. However, if the doctor is okay with having a patient sit in a MAP of 55 range, you can set your alarm to 50. That way, you're only alerted to a change that is actionable. Now we're going to talk a little bit about alarm courtesy. The idea of alarm courtesy contributes to the cohesiveness and harmony on the unit. Remember that it's the responsibility of every nurse to respond to auditory alarms. As such, if you're responding to a condition that has produced an alarm, remember to silence the alarm first as you attend to the alarm condition. Similarly, if you're going to produce an alarm with an intervention, like suctioning a vented patient or drawing back on an arterial line, always remember to pause the alarms first. When other nurses hear continual alarms, they will redirect attention away from their own patients to attend to your alarm. Be conscientious and practice alarm courtesy. Now I want to talk a little bit about IV pump alarms. Although it may be counterintuitive, you actually want to set your IV pump alarm to the loudest volume available, which is 5 on our pumps. This is because if the volume is not loud enough, it will not direct the attention of nurses to come and see about the alarm, but it'll leave the volume just loud enough for a patient alone in a room to be disturbed by the alarm. Setting your alarm to 5 allows the alarm to be handled quickly so that the patient can get back to sleep and you can get back to your regular responsibilities. Let's talk a little bit about ventilator alarms. After speaking with many respiratory therapists, the feedback I've been given is that when your ventilator alarms, you want to identify exactly what is causing the alarm so that you can pass that on to the respiratory therapist for them to adjust their alarms accordingly. The ventilators do have an alarm history. However, depending on how you silence or stop the alarm may decrease the amount of data that the ventilator collects. So always take a quick look when you're silencing your alarm and attending to the alarm condition to figure out exactly what's happening with the ventilator and which parameter is giving the most alarms. This way, respiratory therapists can adjust their alarms accordingly. Let's talk a little bit about safety. When adjusting alarms, there's always the risk that you're going to adjust an alarm with an increased specificity that actually does not alert you to something that is actionable, a condition that you absolutely need to see. Always use the feedback of senior nurses and doctors, the intensivists, physician's assistants, and nurse practitioners to figure out exactly where your alarm parameters should sit if there is any question. Safety should be paramount. When in doubt, reset your alarms to the default settings and go from there to decide if you should adjust them further.